Hello, hello everybody. Welcome to the webinar Candidemia in Transition, Unravelling the Rise and Impact of Candida auris. Good morning, good afternoon, good evening, wherever you are. This is a webinar that it is organized by Turkish ECMUD Society and supported by EFISC of ESCMID. While it's just 2 days before ESCMID Global, it is very important, very interesting, and very important to hear and discuss about the new Candida epidemiology and also Candida treatment challenges. I'm Emmanuel Roilidis. I'm emeritus professor in Aristotle University of Thessaloniki, Greece, and I'm really happy to chair this webinar together with Professor Kilic from Erciyes University in Kayseri, Turkey. So, Esayur, you want to introduce also a few words?
Dear colleagues, welcome again. Yes, as Manuel said, this webinar is organized in collaboration with ESCMID, EFISC study group, and the Turkish Society of Clinical Microbiology and Infectious Disease, ECMUD. We are very pleased to bring together experts from different countries, Turkey and Greece, through this collaboration. As you know, candidemia is one of the most important issues of bloodstream infections. It is associated with high mortality and high morbidity. Despite advances in care, it remains a major clinical challenge. In recent years, we have observed a clear shift in epidemiology globally. Candida auris has emerged as a serious global threat. It spreads easily in healthcare settings. It can cause outbreaks. It's often resistant to multiple antifungal agents. Also, diagnosis is not straightforward. Misidentification can delay appropriate treatment, and also this increases the risk of poor outcomes. At the same time, infection control has become even more critical. Early detection, strict precautions, and coordinated efforts are essential for this microorganism. Treatment is also challenging. Evidence is still evolving, and clinical experience plays a key role. For all these reasons, the topic is highly relevant to our daily practice. Today, I have a great pleasure to co-moderate this session together with Professor Emmanuel Roilides. And I'm Professor Ayşegül Ulukılıç from Erciyes University. And now, today, we are honored to have two excellent speakers with us. Associate Professor İsmail Yılmaz Eren and Associate Professor Elias Iosifidis. They will present their presentations. And Emmanuel, would you please introduce our first speaker?
Yeah. So definitely. Just before I introduce the first speaker, I would like to ask everybody among the participants to use the Q&A session to write questions and comments. So we'll discuss these questions after the two talks. So the two speakers will talk first, and afterwards we will discuss any questions that you may have. So now I can introduce the first speaker, who is, as I said, Professor Elias Iosifidis. He's assistant professor of in pediatrics and infectious diseases in the Aristotle University of Thessaloniki, and he will talk about emerging patterns Candidemia, the expanding footprint of Candida auris. Well, as you know, Candida auris has been changed to Candidozyma auris, but we will continue just for better, easier speaking to talk about Candida auris. So, Elias.
Good afternoon. Thank you very much for the invitation. And as Professor Ludi said, today I will discuss how Candida auris is changing the epidemiology of Candidemia. Even within our field, infectious diseases, fungal infections have traditionally been considered of lower priority, less urgent than bacterial infections, and mainly relevant to immunocompromised hosts. However, Candida auris has challenged all of these assumptions. So, Candida auris has first identified in 2009, and within a remarkable short period of time, it has spread globally across multiple continents. It's a multi-drug resistant yeast associated with invasive infections and substantial mortality. But what truly differentiates Candida auris is not just resistance, it, it, it is its epidemiological behavior. So this is not just a theoretical concern. Within a decade, we have seen a transition from sporadic imported cases to endemic transmission in multiple regions. And this includes parts of Europe. You can see here, in several countries, we are now dealing with sustained healthcare associated spread. And you can see countries from the north that have more sporadic cases, but in south of Europe, like Italy, Greece, and Spain, these countries are now endemic in parts of these countries. If we move beyond Europe and look at the global picture, we see a similar pattern. Candida auris has now been reported across multiple continents. Several countries have already reached endemicity, while others are experiencing increasing numbers of cases. In addition, different clades have emerged, as you can see here, have 1, 3, 4, and in different regions, suggesting parallel evolution rather than a single source spread of this pathogen. And importantly, this expansion has occurred within a remarkably short period of time. The global distribution is only part of the story. What really matters is that different clades, they behave differently. You can see here some clades, particularly from South Asia and South America, are associated with higher outbreak potential and environmental persistence. So what makes Candida auris different? Unlike most other Candida species, Candida auris behaves more like a healthcare-associated bacterial pathogen. It can persist on surfaces and medical equipment. It is efficiently transmitted between patients. It is often misidentified in routine laboratories in most of the microbiology departments. At the same time, it often shows multi-drug resistance, as we said before, which further complicates management. So this is not just another commensal yeast. It is an outbreak-prone pathogen. Here, importantly, Candida auris did not emerge in isolation. Over the past years, we have already observed a shift in the epidemiology of Candidemia from Candida albicans towards non-albicans species. Many of these species are associated with increased antifungal resistance. In this context, Candida auris represents the extreme end of this transition, and this figure is from our hostel in Thessaloniki, and you can see that how Candida auris has emerged through the last 2 to 3 years. Here we have another study. This is data from the ECMM Candida 4 study, focusing on non-albicans Candidemia. And what we observe is that Candida albicans is no longer dominant, and multiple non-albicans species are now responsible for invasive infections. Importantly, Candida auris is already present among the leading species. And you can see here the map that this study has counted from all over the world. And so this is not a future threat. It's already part of the current epidemiology. Candida auris is increasing, sorry, just give me 1 second. So Candida, just give me 1 second because I'm not lost. So Candida auris is increasingly identified in critical ill patients. And now this is from adult critical ill patients, particularly in high prevalence regions. In settings such as such as I have a problem. Just give me 1 second.
Just click on the presentation PowerPoint screen.
Yeah, I'm okay now. So I think you see I'm showing the slides. So in settings such as sorry, there's with the two screens a little bit of problem here, but in settings such as India and South Africa, it already accounts for up to 5 to 10% of Candidemia cases. So importantly, this is not sporadic emergence. It reflects ongoing transmission within healthcare systems, often associated with outbreaks, and in some cases, endemicity, as we said. So this suggests that Candida auris, unfortunately, is not just emerging, it is establishing itself as a nosocomial pathogen. And in some regions, this transition has gone even further. In India, Candida auris has rapidly emerged as a major candida of Candidemia in the most vulnerable patients, which are the neonates and premature neonates in intensive care settings. So you can see, and this is not only in India, the same in South Africa and in Latin America, which means that in certain centers, it's no longer emerging. It has already established, and this is a problem. And if you think that we are talking about neonates, premature neonates, where the treatment options are also very limited. So again, to show you data from neonatal invasive Candidemia from WHO region, and you can see here that maybe we don't, at this point, this study from WHO shows that at this point, Candida auris is mainly one of the most common pathogens in Latin America, but to better understand where Candida auris is emerging in neonates, we also need to look at the broader context of neonatal sepsis globally. So this study, the NEOB study, included 19 sites across 11 countries. You can see it here. These are exactly the environments where Candida auris has been increasingly reported. Looking more closely at neonatal invasive candidiasis, this large prospective cohort provides important insights. Candida auris already accounts for around 14% of cases in this cohort. So even in this setting, Candida auris is not rare. It is already part of the epidemiology. So how is Candida auris transmitted? Transmission occurs primarily through contact. Contaminated surfaces and medical equipment play a key role. We're going to talk also about this. And importantly, colonized patients and occasionally healthcare workers can act as reservoirs. This makes transmission, particularly efficient in healthcare settings. And that's what we see in these countries that we have endemicity. The key question is not only where Candida auris emerged, but why it spread so efficiently. Unlike most Candida species, Candida auris can persist on the skin and on environmental surfaces for prolonged periods. It contaminates medical equipment and patient surroundings, facilitating transmission between patients. And you can understand what happened with COVID. In addition, patients can remain colonized for weeks or even months, acting as reservoirs within healthcare settings. In many ways, Candida auris behaves more like a multi-drug bacteria pathogen than a traditional fungal organism. In this study, which is released a month ago, actually, a key factor behind the efficient spread of Candida auris, it is its ability to persist on the skin. So this recent study have shown that this is not a passive process, but an active biological-driven mechanism. Specific adhesins, we don't need to say the names, but these specific molecules allow the organism to adhere to keratinocytes and extracellular matrix protein in the skin. And other molecules, they also contribute to surface colonization and biofilm formation. This enables actually Candida auris to persist on the skin for prolonged periods, effectively creating a reservoir for transmission within healthcare settings, but also for the patient to be a risk factor for candidemia. Another important question, as Professor Kilt says, we have a problem with the identification. So the question is whether we are actually seeing the full picture. Candida auris is frequently misidentified by conventional laboratory methods, often as other Candida species. So for accurate identification, we need to have advanced techniques such as MALDI-TOF or PCR molecular methods, which may not be available in many places and hospitals. In addition, commonly used fungal biomarkers sometimes have shown limited sensitivity for Candida auris. So it's very likely that the true burden of Candida auris is currently underestimated. Now, from a clinical perspective, and we will and Esma will follow with some very nice and very interesting cases. Candida auris is particularly concerning due to its resistance profile. Many isolates show resistance to multiple fungal classes, especially fluconazole, with variable susceptibility to other agents. We will see it in the next slide. So this significantly limits actually the therapeutic options, particularly in critically ill patients, and think that the case of also for children and also for neonates. In addition, cases of pan-resistant strains have already been reported. This is no longer just a difficult pathogen to control, it is also a difficult pathogen to treat. So here we can see the fungal resistance rates that has been recently published in some studies. So you can see here that resistance to fluconazole goes up to 90%, up to 30% for amphotericin B, and 5% for echinocandins. And of course, the Candida auris has all the mechanisms that can do this resistance, but also the biofilm tolerance. And of course, why does all this matter? Well, the answer is we can understand that Candida auris is associated also with high mortality in invasive infections, particularly in critical ill patients, At the same time, it has the capacity to cause healthcare-associated outbreaks, which means that increasing healthcare costs and resource utilization. And yes, there are a lot of data, a lot of studies now that Candida auris is associated with poor clinical outcomes. Well, of course, this is driven by multi-drug resistance, but also its tendency to affect critically ill and immunocompromised patients. And you can see here the cost that an outbreak can cost. Okay, so across studies, overall mortality is around 40%, and even higher in bloodstream infections, although there's a variability across regions and the burden remains substantial. When we look at pooled data, mortality is significantly higher in patients with bloodstream infections. And there's also variation across region with lower rates reported in Europe. So outcomes are not only poor, they are also heterogeneous. And also here, this is from a study that was published some months ago. And we see here that with taking all this together, we see that Candida auris combines transmissibility, but also resistance and poor outcomes. So given all these challenges, prevention becomes absolutely critical. First, early and accurate identification is essential. Clinicians and laboratories need to be aware of potential misidentification. Second, active surveillance and communication between microbiology laboratories and clinical teams are the key. In high-risk settings, screening on admission becomes an important strategy. For example, this proposed algorithm from an ICU setting said, and actually in our department we use the similar approach. So this algorithm suggests screening patients at admission using molecular methods, and patients who test positive are placed under contact precautions, while those negative may undergo repeated screening. The goal is early detection of colonization before transmission occurs. So screening is not about diagnosis only, but screening is mainly for preventing outbreaks and transmission and outbreaks. In practice, infection prevention relies on few key principles. Strict hand hygiene and appropriate contact precautions are essential. Environmental cleaning and disinfection plays a major role given the organism's ability to persist on surfaces. Equally important is communication between healthcare facilities when patients are transferred. And finally, screening of contacts and ongoing laboratory surveillance. Together, these measures are critical to prevent the spread of this pathogen. In practical terms, control measures are similar to those used to other multi-drug resistant pathogens. Contact precautions, environmental decontamination, patient isolation are very important, and it also we need to think about the education and strict adherence to all these measures, which is very essential. Yeah, cancer care is something for the neonates. If we have time, we can discuss on this. So finally, this is my pre-last, let's say, slide. Outbreaks of Candida auris are rarely due to a single factor. I really like this figure from a study, which was, you can see here, 3 to 4 years ago. But we always know that usually the result for an outbreak comes from multiple breakdowns in infection prevention practices, including delayed patient isolation, poor hand hygiene, inadequate environmental cleaning, and lack of awareness. So Candida auris outbreaks are not just microbiological events. They reflect system-level failures. So Candida auris is redefining Candidemia epidemiology, unfortunately. It is a highly transmissible healthcare-associated pathogen. It is difficult to detect sometimes and difficult to treat. And of course, early recognition and infection control are critical. And with all of this, I would like to thank you and give the voice to the other participants. Thank you.
Thank you, Elias. Now I guess Professor Kilic, you want to introduce the second speaker?
Yes, we will have the questions at the end of the two speakers. So now it's my pleasure to introduce our speaker, Associate Professor Esma Elmas Eren. She is an infectious disease and clinical microbiology specialist at Kayseri City Hospital. She also serves as a head of the Infection Control Committee. She's also an active member of EFISC and young member of ACMM. She has participated in the ESCMID mentorship program during 2023 and 2024. During this period, she worked closely with both Professor Emanuel Brolides and Associate Professor Elias Iosipidis. This collaboration contributed to her clinical and academic experience in medical mycology. Today, she will present practical approach for treating Candida auris Candidemia through case-based learning. Dear Esma, the floor is yours. Thank you.
Can you please turn on your sound, Dr. Esma? We can't hear you. Yes, go on,
I'm
please.
so sorry. Thank you for kindly introducing, and good afternoon, everyone. I'm going to present two cases of Candidemia auris, Candidemia, focusing on practical approaches to management in the intensive care setting. Our first case is an 80 years old female patient. She lived in Kayseri. She presented with shortness of breath and chest pain. She had multiple comorbidities, including diabetes mellitus and hypertension and chronic kidney disease. On admission, her general condition was fair. She was alert, cooperative, and fully oriented. Her Glasgow Coma scales were 15. Vital signs showed tachycardia, tachypnea, and hypoxemia with an oxygen saturation of 85%. On auscultation, wheezing and rays were present, and cardiac examination revealed arrhythmia. She also had bilateral peritibial ödem. Laboratory findings showed leukocytosis with neutrophil predominance. Liver enzymes were normal and inflammatory markers were elevated. And thorax CT showed that there were pulmonary thromboembolism on left lung and consolidation. There were consolidation in left lung. The patient was admitted to intensive care unit and required high flow oxygen therapy. A central venous catheter and a urinary catheter were inserted. The patient on admission, on an infectious disease consultation was requested from us. She was diagnosed with healthcare-associated pneumonia and pulmonary thromboembolia. Blood cultures taken from the patients and parenteral anticoagulant treatment and meropenem therapy was initiated. Blood cultures showed no bacterial growth, and the treatment was continued for 10 days. On 18th date of patient follow-up in intensive care unit, due to chills, shivering, and an increase in acute phase reactance, meropenem therapy was restarted by infectious disease consultant. On the third day of meropenem treatment, yeast growth was detected in the blood culture from central venous catheter and peripheral blood culture. Caspofungin therapy was initiated and central venous catheter removal was recommended. Additional evaluations were performed due to candidemia. Echocardiography showed no vegetation. Ophthalmologic examination revealed no evidence of endophthalmitis, and abdominal ultrasound was unremarkable. The yeast was Candida auris, and the MIC value against caspofungin was 0.51 microgram milliliter. It is important the MIC value against amphotericin B higher than 32 microgram milliliter, and the strains was resistant to fluconazole. Central venous catheter was removed and patient is closely followed. Recatheterization was performed because due to need hemodialysis, and treatment was given for 14 days after the last positive blood culture, and the patient was transferred to internal medicine ward on 14 days after developing candidemia. Our second case was a male patient. He is old, 26 years, and he is a construction worker in Kayseri. He had no chronic disease and any regular medications. He had extensive burn injuries involving his arms, face, hips, and his back. On admission, he was alert and hemodynamically stable. He had second and third degree burns involving approximately 60% of total body surface area. Laboratory findings showed marked leukocytosis and elevated inflammatory markers. He was admitted to burn intensive care unit. He was conspicuous and didn't require respiratory support. A central venous catheter was inserted, and intravenous fluids and wound care were initiated. On the 14th day in the intensive care unit, he developed fever and chills. Blood cultures were taken and meropenem therapy was initiated. There were a graft of gram-negative bacilli was reported in the blood culture bottle. Carbapenem-resistant Klebsiella pneumonia. Carbapenem-resistant Klebsiella pneumonia is a flora member in our intensive care units, and colistin therapy was added to treatment parenterally. And then treatment was meropenem and colistin treatment was stopped on the 12 days after no graft was detected in blood cultures. On day 30 of patient follow-up in intensive care unit, due to chills, shivering, and increase in acute phase reactance, the patient was restarted on parenteral meropenem and colistin empirically. On the third day of treatment, yeast growth was reported in the blood culture, and caspofungin therapy was added. Central venous catheter removal was recommended. The yeast was Candida auris, and the strain against fluconazole has MIC value very high, and caspofungin MIC value 2 microgram milliliter. Additional evaluations were normal, and The catheter could not be removed due to extensive burns, but Candida auris was growth in blood cultures taken on days 4, 6, and 80 day of treatment. A peripheral temporary venous catheter was inserted and central venous catheter was removed. Cultures taken after catheter removal showed no growth. Treatment was given for 14 days after the last positive culture, and the patient was discharged 40 days after developing candidemia. In our both cases have intensive care unit stay, use of broad spectrum antibiotics, central venous catheters, and they were common contributing factors for candidemia. I would like to highlight some important points regarding of treatment of Candida auris candidiasis. Echinocandins are recommended as the first-line treatment in CDC guideline for adults and children over 2 months old. Amphotericin B-deoxycholat is recommended under 2 months infants. If there is a resistance or no response, we can switch to other group antifungals, especially liposomal amphotericin B. However, MIC values may vary like our cases. Treatment should always be individualized. And in the European Confederation Medical Mycology guideline, which Professor Roy Lidoes is a co-author in this guideline, echinocandins are recommended as the first-line treatment for all cases of candidiasis, including Candida auris. But one important issue is increasing antifungal resistance. So patients must be monitored closely about response of treatment candidemia. Early antifungal treatment is essential for treatment of candidemia, especially Candida auris. But source control, especially catheter removal, is just as important. Both of them, early antifungal therapy and source control, should be done as early as possible. And thank you very much.
Thank you very much for both presentations. We now have time for discussion. We will be very happy to receive your questions and comments. Please write your questions in Q&A section because chat section is closed. So we will review them and direct them to the speakers. We also welcome your contributions and shared experiences. May I ask a question to both speakers? What is the proportion of Candida auris in your hospitals? Do you know?
I can say we have 12 candidemia cases from 2023. And I can say 2 patients are alive, unfortunately.
What's the proportion of with all the Candidemia strains?
It depends on which intensive care unit. Our results, according to our results, Candida paraphysiolosis is major strain for us.
And what is in your institution, Ilyas?
Yeah, thank you very much.
What's the proportion of Candida auris?
Yeah, as I said, one of the slides was from our hospital, and unfortunately, we have a high prevalence of Candida auris and Candidemia. The good thing is that mainly, actually, only in the adult departments. So the frequency is 30%. It depends. I mean, this 30% was at least for 2024, and sometimes, it is the second, and we hope it's not the first pathogen between the Candida isolates in our hospital. We do a lot of measures that we try to reduce colonization and bacteremia, but unfortunately we are an endemic hospital, as most hospitals in tertiary level hospitals in Greece. The good thing is that although we have a lot of pediatric and neonatal departments within the same hospital, where adult departments are endemic for Candida auris, and sometimes we had spillovers from the adult departments to the pediatric and neonatal departments. We have no infection actually in children, and this is what keeps us happy, that we can do a lot. We have a lot of things to do, but we already started to do some things in terms of prevention, both of colonization but also infections. Thank you.
Thank
So Elias,
And,
since you are talking, I'm sorry, Sayel.
And Ilyas, also you said during your presentation, Candida auris is now part of your epidemiology. It's not rare, but like other non-albicans Candida strains, Candida auris is a part of epidemiology. In your hospital or in all country?
Yeah, if we talk about for neonates, the good thing is that it's not the case, at least in Greece. We see a lot of invasive candidiasis from cadavers from other countries like India, as I presented, or South Africa, Latin America. But fortunately, it's not the case, at least in Greece now. The same also for pediatric patients. I would say that at least for Greece, the main problem goes for adults and mainly critically ill patients in adult ICUs. I don't know if Professor Iris wants to add on this.
No, I think
Professor Emil, we have some questions, I think. Did you see? But they write in chat section.
Well, actually, there is a relevant question in the Q&A section, which is Elias, you talked about measures, and of course, the first measure is rapid diagnosis to know that this patient coming into the hospital is colonized, and you saw how easily a patient can be colonized in his skin. And the second is, of course, to isolate him or her. And is there a specific disinfectant that we need to use, or there are no recommendations of any disinfection of these patients? I mean, we know that having Candida auris is like the colonization can be for a long time, even after going out of the hospital. Actually, these patients unfortunately, they are so sick, they go out, they go maybe to another hospital afterwards and come back to the hospital. So they are like transmitters in the whole community, in the hospital. So is there a disinfectant specific for Candida auris, working Candida auris?
Well, first of all, thank you very much for this question. It's a great question and very relevant. The answer is quite challenging because, well, at least there are some guidance from CDC, and some other countries. So I would say that at least starting with CDC for surfaces, what is good to use in practice, they have an EPA list with P product, and they say that if they have if they say that this is for Candida auris, then you should use it. Otherwise, we know that chlorine 1000 ppm or 0.1% or hydrogen peroxide based disinfectant. And of course, we as also said in my presentation, we need a proper cleaning first, correct wet contact time, and avoid using quaternary ammonium compounds. we know them as quads alone. So maybe we should not use quads alone. This is for the environment, for the skin and the patient's skin, because we know that, as you said, we know that Candida auris colonize patients for a long time. There's no universally accepted routine decolonization protocol. Even with chlorhexidine bathing, it may be considered as an adjunct in outbreak or high-risk settings, but not as a reliable or stand-alone solution. Of course, yeah, for skin preparation, it's the standard of care that we use, like alcohol-based chlorhexidine or povidone iodine. So this is for the preparation for line insertion or surgery. The good thing is that skin and for the skin hygiene, no special added Candida auris skin disinfectant is required.
And another question for maybe Esma say something about that. I guess do you use Esma Chromagar in your microbiology department in your hospital? Chromagar screening
Yes, we
growth
use
factors?
Chromagar for screening.
Mhm. The question is that
Yes.
what do you think of this specific Chromagar Candida Plus? Can this product be used for screening purposes? Can Candida auris be used, be identified by Chromagar? And you are,
Um, in my opinion, we can reach rapidly results.
mhm.
I think
Yeah, yeah. I've actually, yeah.
routinely.
Yeah, definitely. There is different color, but it's very difficult to sometimes to separate. There are mistakes as well. So I think it's good for screening, but not so precise as maybe PCR or something like that. Just going back to Elias' response, any patient who gets into the ICU in the hospital, in our hospital, gets a PCR for Candida auris to make sure that he's not colonized. He's not bringing the Candida auris from outside to the ICU. So there are
Also,
also other interesting questions. I mean, I suggest you want to take some other
some
questions.
studies have shown that being black could be a risk factor. Have you heard of this? If so, what are your thoughts on it? I think race itself is not considered as a independent risk factor, but maybe some studies found this, but generally it's not an independent risk factor, I think. What do you think, Elias?
Yeah, I also, yeah, I totally agree with you because at least what we know, what we have, in the literature, yes, we know that there's a predominance for low middle income countries. We also said so about the India, the South Africa, Latin America, but yeah, no, I don't think this is something that we need to, yeah, elaborate on.
But
Um,
maybe Elias, the study you mentioned, the very recent study you mentioned about Candida auris adhering on keratocytes, it's very interesting. Maybe there is a difference there in keratinocytes of, I don't know, depending on the
Yeah.
the color as well. I mean, just a thought. I don't know. Probably, yeah, it's not a
The
correlation.
main risk factors may be critical illness, prolonged hospitalization, invasive procedures, prior antibiotic exposures, but not the race is an independent risk factor for Candida auris infections or colonizations.
Yeah.
Environmental factors may be affect.
And also, we don't have a lot of data from Africa. This is also another issue, as always. So it's quite difficult for these countries to identify Yeah, but it's interesting. I mean, yes, there's a lot of areas that we need to know more for cat auris.
Yes, you are
Yeah.
right. And a question for Esma. Why is her considered from the first admission as a healthcare associated pneumonia?
There were a lot of admission to hospital uh, because pulmonary thromboembolia. I forget it. I'm sorry.
And also they ask what specific acute phase reactants were elevated in these cases?
CRP, procalcitonin at leukocyte level we use routinely, and in this case,
Any head-to-head trial amongst different echinocandins for Candida auris treatment? As I know, there is not a trial comparing three or different echinocandins for treatment of Candida auris infections. Do you know?
No.
Any?
No, there's no. I mean, just one thing. As a pediatrician now, echinocandins. I mean, since auris is very common, as Elias said, actually in low middle income countries like South Africa, India, especially in neonates, echinocandins can be also used or should be used in neonates as well. Actually, even in premature neonates. The only difference is the anidulafungin. Anidulafungin cannot be used in patients younger than 1 month, but micafungin or caspofungin, actually micafungin is usually used in neonates. So that's something that at least there is a drug to treat these very little patients with auris. There are some other questions as well. I mean, Isaac, if you want to take
No,
them.
you can read.
Okay, so let's see. Besides, there's a question here from Ahmed Nayat Kafari. Besides patients, would you recommend the screening of healthcare providers, especially ICU staff for Candida auris? I guess for everybody, I mean, Elias or Esma, want to respond to
Think
that?
this is something that we always think about. That was the same for Klebsiella resistant and other Acinetobacter. I think the answer is not yes or no, because we know that we are transient colonizer, let's say. The big issue is about the hand hygiene, our hands of the healthcare workers, and also the barrier. The barrier, so using actually, the gloves, the contact precautions. If we use these, then it's the way that we protect our patient. However, if this is included in the measures that an institution would like to have, yeah, this can be also be part of the measures. But we always need to think about, which is the appropriate way of touching the patients, which means the basic and precautions and also contact precautions.
There's a question for, I guess, asthma for treatment. In a patient that has persistent Candida auris blood cultures with poor source control, surgical site infection, for example, despite adequate caspofungin treatment according to antibiogram, what therapeutic measure would you consider? Double dose Candin, switch of Candin, or addition of a second antifungal? So this patient is that he is on echinocandin, like caspofungin, and he continues to have Candida auris blood cultures, unlike from your patient. So what do you do?
It should be considered combination therapy, different group antifungals according to MIC levels.
Well, and I start with I'm sorry, with amphotericin B, I guess.
Yes,
Azole is
amphotericin
not
B.
working. Yeah.
Uh-huh.
Okay. So amphotericin B
Do you
plus
prefer combination therapy with two antifungals when you have persistent positive blood cultures? Esma? Combination therapy or
Yeah,
in your case, because of the resistance to several antifungals, catheter removal was very effective to control the infection.
yes, yes.
In your second case, I think.
The catheter is removed, but I was planned the voriconazole therapy if catheter not removed.
Mhm. Yeah. Well, there's yeah. Well, I mean, I guess if there's catheter should be removed, and you know, those of course should be the highest that one can give, but sometimes maybe you have to use also combination therapy with both echinocandin and also amphotericin B, assuming that there is also susceptible to amphotericin B, because sometimes Elias showed the 30% resistance actually worldwide. So there are several questions about screening. So how should we do the screening also for the healthcare personnel? So Elias, again, I guess this is similar to previous one. So if you want to respond to
I
that.
want to say that for Candida, what we want, the place is, let's say, that we all routinely screen is the groin, nares, and axilla. And yes, so yeah, probably the same could be with the healthcare providers.
Mhm. So okay, so this
Also
is
have the hands, and also, I mean, there's also some studies saying that I mean, they have compared which is the best site for screening. So they have found that there were colonized patients that were negative to groin, nares, and axilla places sites, and they have found this in other place. But yes, it's a long story, but I think the first thing is that at least to screen with the capacity that we have, especially when we have our first case, so that we can see the spread of the micro of Candida in our institution, and we can use the regular sites like axilla, groin, and nares.
Here's a question by Navin Kumar, which is actually something that we should discuss. What is the average duration of developing Candida auris, Candidemia, after hospitalization ICU? What is the rate of echinocandins resistance? How to manage such effect? Well, this is, I guess, it's everything. I mean, we have discussed about, but the duration, I guess, of getting Candida auris colonization first, and afterwards maybe Candidemia. Do you have any data, Elias or Esma?
I have small data, but I think after 2 week the admission.
After 2 admissions,
The second week.
2 week.
2 weeks,
2 week.
2 weeks admission.
2 weeks in your hospital, I think.
Yes.
Mm.
This is a small data.
Okay. Are you talking about colonization or about Candidemia?
Candidemia.
Candidemia. Okay. Yeah. And a relevant question is how long does it take if a patient gets colonized and there's not so good way to disinfect this patient? How long this patient should be considered colonized and be on prevention measures?
Yeah, that's another very good question. Actually, according to the CDC, says once you are colonized, you are always colonized for this and also the next admissions. Yeah, probably we don't know. We don't have enough studies. So maybe yes, the best is we don't know for how long. So you are supposed to be colonized for the current hospitalization, but also for the upcoming ones. There are some centers also in our sense that we try to do something like decolonization, but all these measures have been failed, and there's not something like a standard protocol saying that if you use this decolonization protocol, your patient will be negative. And also it goes again with which are the sites that you need to screen, with which methodology, and all this emerging data for the skin colonization. And it's not only skin, it goes deeper. Then probably it's for the moment we can say once colonized, he should be on measures for all the duration of his hospitalization.
So since it's Dr. Kilic, should continue or
We
finalize
are
the webinar?
over the time. I read the questions, and the remaining questions are all about infection control and surveillance screening for healthcare personnel. If you want to say one more about these questions, Elias, the questions is more about infection control measures. What's your recommendation in institution for Candida auris, emerging Candida auris infections? Which infection control measures do you use? Do you screen healthcare providers? When do you discontinue in patients with Candida auris candemia? If you can say in few words, we will all answer the remaining questions.
Okay, thank you very much. So I think if you have the first cases and you are not endemic in your institution, I would say that give a priority to Candida auris. Early identification, do surveillance, isolate the patient and contact precaution, good hand hygiene, strict environmental cleaning and disinfection. So give priority number one for Candida auris if it's the first case or the first two cases. And try to have the staff and workflow control, communication, and educate and train your patient. Maybe if you have very few cases, you can have a contact person from the healthcare workers that they can ask him questions like a hotline, so that everyone can take these measures, because it's very significant to stop the spread from the first case that you have found in your institution. Otherwise, it's very difficult and for endemic cases to stop the spread.
Thank you very much for all. There was a lot of questions. I only share some of them with you because our time is over just now. Thank you very much for two speakers. Thank you for all your participation. And Emmanuel.
No, thank you very much. That was it was a very, very interesting webinar, and thanks for all the participants who took part and had all these interesting questions. And see some of you in a couple of days at the ESCMID Global in Munich, I guess. So
Yes.
thank you very, very much.
Thank
Thank you
you.
very much.
Bye-bye.
Thank you very much.
Bye. Bye.
Bye.